evening. Hi, it's Sunday at 6 o'clock in the UK, and I'm going to do my Instagram live tonight about mental health and hormones because it's a topic that comes up a lot and is often under-recognised and under-treated and under-diagnosed, meaning that lots of people are suffering. So I'm just going to start at the basics and just build up. You've given me lots and lots of questions, and I have read them all, and I'll try and piece as many things together to make it easier for you to understand. Dr. Rebecca Lewis, who's a clinical director with me at Newson Health, is going to be on and will try and answer a few questions. And obviously we've got a huge amount of information both on the free Balance app and also on the balance-menopause.com website as well. So just to unpick things, start at the basics is how I've always learnt things in medicine and in life actually. Let's not overcomplicate things. So thinking about what the menopause is, I've said before and I'll say it again that for many years, in fact for centuries, the menopause has been defined at stopping our periods, and indeed that's how you make the official diagnosis, to have a year since your last period. A lot of women don't have periods, or they might have very irregular periods. And so other people then define it as fertility, whether we're fertile or not. But actually that's not relevant for many women and not appropriate to be thinking about women as whether they can conceive or not. So let's think what actually happens. Well, what happens is our hormone levels decline from our ovaries for lots of different reasons. For most women, it's just because we age. And as we get older, our ovaries don't work as well. So the hormones that our ovaries produce have a lower level. So the hormones that we talk about are so-called sex hormones, but they're not all about sex, and they don't even define us as female. So they're estradiol, which is estrogen, progesterone and testosterone, three hormones that our ovary produces. But it's not just our ovaries that produce these hormones actually. We know that our brain produces these hormones as well. Now, hormones are just chemicals that go into our bloodstream and go all around our body. Obviously our blood supplies every single cell in our body, and every single cell in our body responds to these hormones, estradiol, progesterone and testosterone, as well as a myriad of other hormones as well. Now hormones, when they have receptors on the cells for each of these hormones, and when the cells respond to these hormones, it triggers a whole cascade of reactions, chemical reactions if you like, in the cells and in the body to make us function. Now if we're thinking about the brain, all three hormones work in the brain. They affect the way our brains work. And the reason this is important to know is that you'll soon realise that if your levels are changing or low, for many women their brain doesn't work in the same way. Now there's lots and lots of ways our hormones work in our brain, and these are just hormones. I'm not talking about HRT, I'm talking about our natural hormones, how we function as women, and even men as well, and other people too who don't define themselves as men and women. Of course, everybody's got these sex hormones in their bodies. So women have testosterone, men have estradiol. It's very under-researched estradiol in men, and it's still not very well researched testosterone in women. But we know from basic neuroscience that estradiol, progesterone and testosterone are produced in our brains, and they have important protective roles in their brain. So they work as neurotransmitters. So neurotransmitter just means a chemical in the brain that affects the way our brain cells work, and they also are messengers from one, so they interact with other neurotransmitters. We've got lots of neurotransmitters, not just estrogen, progesterone, testosterone. They're ones such as serotonin, our happy hormone, which you might have heard of, dopamine, which is our reward hormone that you might have heard of, or neurotransmitter. There's glutamate, there's GABA, there's also adrenaline and noradrenaline and acetylcholine, and all these neurotransmitters work together. So if we've got less of one, we're going to have less of another as well. And sometimes that can be really relevant when we're thinking, for example, about serotonin, our happy hormone, because if we've got less estrogen, we then have less serotonin as well. And then you can see how mood can really be affected in the menopause. So we also know that these hormones, estrogen, progesterone and testosterone, help build our nerve cells. They actually improve the connection between one nerve cell and the other, and they actually can build the myelin, which is the sort of protective part of the physical nerves, and helps the chemical messenger, or the messenger through the nerves, go even faster. Now, our brain defines everything that we do. It defines our personality, of course, our memory, our reasoning, our verbal and our non-verbal reasoning, how we sleep, but also all our physical reactions in our body. So the way we breathe, the way our heart beats, the way our bowels work, the way we move our arms and legs, the way we speak, everything is determined by our brains. So the healthier our brains are, the better. Now, there's lots that keeps our brains healthy. We know that, obviously, and I don't need to remind you, eating healthily is really crucial for our brain function. Trying to reduce sort of processed foods, sugars, trying to eat the rainbow, really feed our gut microbes, which can help our serotonin levels also in our brain. We know that. We know resting is really important. We know sleep is really important for our brain, because it's the time when our brain can repair itself, and our body as well. And we know that sleep is essential. We also know that not drinking alcohol in excess, not smoking, is really important. Exercise, of course, is really important for our hormones. We do know some types of exercise, though, certainly as we get older, can produce more stress hormones, so our adrenaline and cortisol, which can sometimes have a negative effect on our mood. Some people find it really beneficial. So doing the exercise that's right for you is really important. As many of you know, I do yoga, so this morning when I finish my yoga practice, I always do a headstand, and I'm sure, I hope, that doing a headstand is really good for our cerebral brain flow, and just having your body upside down is quite good. So there's lots of things that we can do to improve the way our brains work. But what I do want to talk to you in more detail is about the role of our hormones. If we think about depression, so clinical depression, that's not just having a bad day where you feel a bit low. It's when it persists and people feel very low in their mood, certainly worse in the morning, often associated with other symptoms where people feel not interested in things. They've got little interest for the future as well, and sometimes people find they lose weight when they're depressed. Some people comfort eat when they're depressed. There's no blood test for depression. It's often by a collection of symptoms, and these mood changes persists. Very, very common. Now, it's estimated that there's 280 million people worldwide with depression. I'll say that again, 280 million people in the world with depression who are women. Now, what's even more depressing than that is 75% of people in middle or lower income areas are not receiving any treatment at all for their depression. So there's lots of people who are really suffering in the world. And when we look at population health and global health, which is what I'm very interested in, why are these women and people not improving? Now, there's lots of treatments for depression, and I'm not going to go into all of them here, but we've known for many years that lifestyle can improve mood, like I've said already. All those things that help our brain to function can help. We also know that antidepressants can help, and SSRIs can help, which are selective serotonin reactive inhibitors. So these are drugs that actually just increase the amount of serotonin in our brain. There's a whole myriad of ones. Sometimes if people don't respond to SSRIs or SNRIs, then there's other types of drugs that sometimes the psychiatrists use. We see people on drugs such as pregabalin or quetiapine or antipsychotics, or even lithium. And for more extreme cases of treatment-resistant depression, there are treatments such as ECT, electroconvulsive therapy, and other treatments that sometimes are used more as an experiment when we haven't got proper randomised control studies to see the results. But I'm not a psychiatrist. Obviously, I'm a GP. I've done psychiatry training, And in general practice, we used to prescribe, or I used to prescribe, and people still do a lot of antidepressants. Now, getting back to sex hormones in our brains, I've already said that for some people, they find that their hormone levels, when they change in the brain, can really be affecting them. We've known for many years that the symptoms of the menopause really are very different for everybody. But it's not just the menopause, it's not just when our periods have stopped and our hormone levels are low. We need to think about this perimenopause, which is the time before our periods stop, when hormone levels start to change. And like I've said before, they don't just decline slowly, they often decline in a very haphazard way. So they can be high, they can be low, they can be all over the place. Sometimes people find their periods are heavier and closer together. Sometimes people find their periods are more scanty and lighter. But like I say, lots of people don't have periods. The menopause symptoms and perimenopause symptoms are actually exactly the same. What they are symptoms that our body is creating due to these changing hormone levels. The perimenopause can be hard to actually diagnose what's going on because there isn't an actual blood test or urine test or saliva test. It's usually diagnosed by patients or women understanding that it might be a hormonal problem. Some people find that their brain is very sensitive, a lot more sensitive than others. And when you look at the commonest symptoms of the perimenopause and menopause, they're not hot flushes and sweats actually. They're the symptoms affecting our brain. So people report low mood, they report anxiety, brain fog, poor sleep, little interested in things, difficulty getting to sleep as well. Just feeling like, a lot of people say to me, I just feel flat. My zest for life has gone. I'm joyless. I'm just existing. I'm not really looking forward to anything. Everything's dark. The shutters have come down. I hear quotes like this every single day in my clinic when I see new patients. And it's this very much like I really don't want to carry on. And for some women, it can be a very overwhelming negative thought where they actually really don't want to carry on. And we know that the diagnosis of depression increases in women in their late 40s. And we also know that suicide rates increase by a factor of about 7 in women in their late 40s. Now, I'm not saying every woman in their late 40s is going to be clinically depressed or have suicidal thoughts. And I'm also not saying that everybody who is depressed or has suicidal thoughts, it will be related to their hormones. But what I am saying is there's lots of women who are not, whose doctors are not thinking about hormones when they're thinking about their clinical depression or their suicidal thoughts. And it's very difficult to know. How do we know as clinicians if someone is depressed, or as in they've got clinical depression, or is it related to their hormones? And it's not just clinical depression actually. We know there's an increased incidence of bipolar depression, of schizophrenia, of psychosis, of drug addiction. All these psychiatric conditions actually increase in women in their late 40s, and so some of it is bound to be hormonal. Now, there's a term we often use called reproductive depression, and that actually means for those women, they're more sensitive to their sex hormones at certain times in their life, which includes the perimenopause, but it also includes postnatal time. So a lot of women have postnatal depression, and also PMS or PMDD. So PMS is premenstrual syndrome and PMDD is premenstrual dysphoric disorder, which is a more severe form of PMS. Some studies say about a third of women have PMS, and I think it's probably more than that. Most of us have had times where we feel low, flatter, maybe more anxious for a day or two or 3 or 4 days before our periods come. Our periods start and then we feel a lot better. Now, just physiologically, that's what happens in our bodies, that our hormone levels, especially estrogen and progesterone, are very low, and they're very low in the couple of days or so before our periods. Some women don't notice a change, but others do. And we know when there's a drop in our hormones that can trigger these feelings because our brain is not having the same symptoms. Our brain isn't having the same hormones as it was earlier on in our cycle. If you think in pregnancy, and I put a graph of of somebody how their levels change when they're pregnant on one of my Instagram posts a couple of weeks or so ago. But we know levels are very high, especially of estradiol, of estrogen, and also progesterone and testosterone actually when a woman's pregnant. Now, if you think when a woman is menstruating, on average her estradiol level can be up to about 1,000. When a woman's pregnant, it can be up to 66,000. So it's a massive difference. But many women then feel great when they're pregnant. Now, when a woman's had a baby, the estradiol level falls off a cliff. It becomes very, very low very quickly. And so there are some women, and it's usually the same women, not always, but there's a lot of women who suffer from PMDD or PMS and then have had postnatal depression. And then when they become perimenopausal, everything gets worse again. And these women often say, it's very similar symptoms to how I had before, but actually they're worse and they're lasting for longer. I could cope when it was 1 or 2 days before my period, but now actually they're happening for 6 or 7 days or 2 weeks or 3 weeks or persisting. And this is because hormone levels are changing and lowering and staying low as we get older. There are some people obviously who have a surgical menopause, have their ovaries removed overnight. And I've spoken and seen to a lot of women who've literally had a psychosis or a very bad depressive episode straight after having their ovaries removed because their hormone levels were absolutely fine. Then literally the day after they had their operation, their hormone levels really reduced, and that can trigger all sorts of symptoms, showing that our brain is very sensitive when our hormone levels are low. For some women, like I say, we don't know how we diagnose these women or what it is about these women who are more sensitive, or their brains are more sensitive to their hormones, but there are a lot of those people out there, and sadly often they're not being diagnosed soon enough. And like I say, we don't know. There isn't an easy diagnostic test to see if someone is clinically depressed or menopausal. But we have to remember actually that people can be both. Now, we know from different studies, I did a study about 7 years ago now, and showed that about 2/3 of women, 66% of women who were menopausal or perimenopausal had been offered or given antidepressants instead of HRT. Now, we did a study recently about a year or so ago, and that's reduced. It was about 33% of people that we used in our survey, but that's still 1/3 of women. Now, let's think about treatment. If we know that the symptoms are related to hormonal changes, then in medicine, isn't it best to give to treat the underlying cause? So if it's obvious that it's related to hormones, then usually replacing the hormones can improve symptoms. And often women will say, I know it's related to my hormones because I felt exactly like this before, and I know I'm not depressed, I just feel flat. And there are a lot of women who say, I feel really low and flat, then my period comes, then I feel better, and then I'm fine for a week or 2 or 3 weeks, and then those symptoms come. Now, we don't have to wait until you're definitely menopausal before treating. And the same with PMS and PMDD, actually. We see quite a few women in our clinic who aren't perimenopausal. They're younger, and they're just having that dip for a few days before their periods. Now, I was always taught when I did my menopause training that it's quite safe to top up hormones just for those few days when people are suffering. And the first time I heard a menopause specialist tell me that, I said, oh, but we were always taught to give antidepressants, and some of the guidelines actually for PMS and PMDD talk about giving antidepressants. And he said, but Louise, isn't it safer just to give natural hormones back? And I thought, actually, you're absolutely right. And so often we do give hormones, and it's always difficult to know which is the most important hormone for women. Is it estrogen, is it progesterone, or is it testosterone, or is it a combination? And it's often the balance of all three is really important for many of us. And it's very difficult to know because we can't do the tests because hormone levels fluctuate all the time. So I could do a test one day, and then the next day it would be different, and the third day it would be completely different. So often it's a symptomatic improvement that we're looking for. So if I'm seeing someone in our clinic and I don't know whether they've got clinical depression or it's related to their hormones, and I'm concerned about their mental health, well, there's no harm giving antidepressants and HRT. There isn't any evidence that giving HRT, There isn't any evidence that giving antidepressants for the low mood that's associated with the perimenopause or menopause is going to be beneficial. And we know that from studies. It's because it's not treating the underlying cause. Many women who I speak to who have been given antidepressants say to me, do you know what, I just felt flat. I felt numb. It didn't help, but I was too scared to stop because I didn't want to feel worse. You normally know if antidepressants are going to help after 2 or 3 weeks. Not necessarily feel better. It can take a few months if people are clinically depressed and need antidepressants. So we can use both, and I'll come back to why it's important to consider both in a minute. But often we replace missing hormones for lots of reasons. So if I see someone in my clinic, they've often got other symptoms as well. They might be having headaches, palpitations, joint pains, muscle stiffness, urinary symptoms. They might be having itchy skin, dry skin. They might be having pins and needles, tinnitus, dry eyes, sore mouth. All of these are symptoms related to our low hormones. And so I know that giving back hormones will improve their symptoms if they're caused by the low and changing hormone levels. But we also know, and I've mentioned before many times, that there are good studies that we know that when women have hormones, then they have a reduction risk of really important diseases, including cardiovascular disease, osteoporosis, diabetes, and dementia. We also know there's a lower risk of mental health conditions, including clinical depression, for women who have HRT. And so that's important when we're thinking about trying to prevent clinical depression, which I've already said is so common. Studies have shown when women are given HRT early, then they reduce their incidence of clinical depression going forwards. Now, there are studies that show that women who have HRT it actually improves their mood, and we've shown that in our clinic, just looking, because we give everyone the questionnaire, the same questionnaire that's on the Balance app, and we can see that mental health symptoms improve. So low mood, anxiety, tiredness, fatigue, those symptoms often really do improve, which is no surprise because we're just giving the hormones back. Now, trying to get the right dose and the right type can be quite difficult for some people, especially in the perimenopause, because hormone levels are fluctuating. So we often start with a moderate dose of estrogen, and some people with time need the dose increasing to make sure that you're replacing what's missing. What we give into the blood is through the skin. Now, the estrogen has to go through the skin into the bloodstream, then into the bloodstream round the body, and through what we call the blood-brain barrier. So there's like a barrier really, because the brain doesn't want to be exposed to everything in our bloodstream, so it's a filter. So sometimes people need to have a higher dose to get the right amount into the brain. There is no way of measuring how much of each hormone we have in our brain. Even doing a brain scan, we cannot see. So what we measure in the blood is not going to be what's in the brain. And what we don't know, because no one's done research, is what are the levels like in the brain of estrogen, progesterone and testosterone in someone who's got depression, someone who's got psychosis or schizophrenia, or someone who's perimenopausal with mood-related symptoms. There are some studies, only small studies, that show that women respond actually better to higher doses when they've got schizophrenia or they've got severe depression. But the studies haven't been done big enough to really understand. But it might be that for some women, a higher dose is beneficial to actually get into the brain. And we certainly see that with progesterone. There are some women who say, I can't tolerate progesterone. I've been on the mini pill. It sent me mad. I felt really low and flat with it. But the mini pill is a synthetic progestogen. The natural progesterone, is very anti-inflammatory in the brain and can be very beneficial for mood, can also help sleep, and also make people feel quite calm and less anxious. Now, the best way of having progesterone is through the mouth and having or vaginally, and I'll explain why in a minute. But the progesterone is the natural progesterone. So in the UK, it's Utrogestan, which is micronized progesterone. So it's very different to the mini pill, which is synthetic, so it's been chemically altered. This is exactly the same as the progesterone we produce ourselves from our ovaries when we're younger. Now, the progesterone can be taken as a capsule. We normally advise to be taken at night time in the evening because it can make people feel a bit more sleepy and tired, which is quite a nice side effect actually. But it still gets broken down by the liver to other types of progesterone. To make it absorbed as pure progesterone, then you can use it vaginally. So the same capsule can be inserted into the vagina, or there are pessaries, which I have mentioned before. So in the UK, there's one called Cyclogest, which can be used in the vagina or in the rectum. And we're using those two places for it just to be absorbed into the body as the pure progesterone. And there are some women who actually need higher doses of progesterone so that it goes into the blood through the blood-brain barrier and can really affect and improve mental health. So if you feel that you haven't improved or you've had problems with a lower dose of progesterone, then there is some clinical evidence that that can help. And it's been written about for many, many years, but actually ignored. And I'm not quite sure why, because it is just a natural hormone to try. And it works quite quickly in the body. So some people will notice an improvement fairly quickly. But we're all different, and so it's really important that you speak to a menopause specialist who really understands how individualisation of hormones is so important. When our hormones work in our body, they, like I say, they trigger a cascade of chemical reactions, and so they can work quite quickly, but they also can change our genetic makeup. They can alter genes in our body. Now that takes quite a long time. So often when we treat menopausal and perimenopausal women or younger women with PMS and PMDD, you have to be patient, you have to wait, and that's really difficult. I know it is, because I know when I started my HRT, I was desperate to feel better overnight. For some women, it can take 3 to 6 months to really improve, and we have to be patient. And that's probably, we don't know because the evidence hasn't been done on each person, but it's probably because of the genetic changes as well. The body has to make quite a lot of changes to really improve and then to have these longer term benefits as well. So try and bear with it every time that you have a change to your dose or type of HRT. But certainly we always try and give the estrogen through the skin as a patch or gel, less so the spray because it doesn't get absorbed very well and it can be a bit chaotic the way it is absorbed. But patches or gel at the right dose is really important. We do sometimes measure levels when people are on a patch or gel, but we have to be careful because if you use a gel in the morning and then you have your blood test taken from the same arm, it can alter the results. So it's better not to use your arms in the morning of the blood test. Even with the patches, there can be some variation because it's the way that the drug is metabolized and eliminated and also absorbed as well. But it can give us a guide. So if someone's still struggling with symptoms and their level is low when we do a blood test, we know we can increase the dose because they're obviously not absorbing adequately through the skin. Now, I mentioned a few minutes ago about using antidepressants and HRT together. Now, this is really interesting actually. There are some studies that show that women who have estrogen in their body, the SSRIs, so the antidepressants we commonly use, work better in the presence of estrogen. Now that's really important and relevant because we know, and I've said already, that estrogen increases the levels of serotonin in our brain, which is our happy hormone, which is the way SSRIs work. Now, if women are still having periods, they're producing estrogen. But if they haven't got periods or they're older, or women in their 50s, 60s, 70s, 80s and 90s, they will have low estrogen because that's what happens. So because of this evidence, in my mind, anybody that's prescribed an SSRI should also be considered for estrogen and HRT as well, because the SSRIs, bit of a mouthful, the SSRIs are going to actually work better. And that's really important when we're looking at dosing of medication. Actually, as doctors, we don't want to be prescribing drugs to people. It's really lovely if we can reduce doses and reduce number of medications people are on. I know Big Pharma don't like it, but for individuals, it's really good to not have chemicals in our body. So actually, if being on estrogen and HRT and an antidepressant means that your antidepressant dose can be a bit lower, or you don't need to have 2 or 3 different types of psychiatric medication, then that's got to be really useful as well. In our clinic, we see lots of people who have been under psychiatrists. They have had very low mood. They have sometimes been sectioned because they've had suicidal thoughts, yet no one's actually thought about their hormones. And I've done a few podcasts. There's a podcast with someone called Vanessa. There's also a podcast with someone called Lindsay. And there's a few other podcasts as well, especially there's one I've done with Professor called Carney from Melbourne University, who's a psychiatrist. All of those are worth listening to if you're interested in mental health. Also Claire Crockett's, she's a doctor who works with us in the clinic, and Hannah Ward as well. They've both spoken very bravely and openly about their own experience, which is really, really, it's quite harrowing actually to listen, because these are very clever people who have been trained but couldn't recognise the symptoms in themselves, and when they did, they struggled to get help. So we all know as healthcare professionals, it can be really difficult for women to receive help and advice and the right treatment. So what I'm trying to say here is that if you don't receive the right treatment that feels right for you in your first consultation, you absolutely are allowed to go and see someone else just to talk through whether you think a different treatment might be useful, or an additional treatment as well. In our clinic, about 1/3 of women we see are already on HRT, but it indicates they're not on the right dose or type of HRT. Now with HRT, most people think it's just the 2 hormones, estrogen and progesterone. And like I've said, they have very important effects in our brain. But there's this other hormone, testosterone. Now testosterone is produced in higher quantities than estrogen when we're younger, and levels decline as we age. It gets produced by our ovaries, also our adrenal glands, and also our brains as well. When anything's produced in our brain, it shows it's important for our brain. Symptoms of testosterone deficiency can include low mood, reduced motivation, loss of interest in things, poor sleep, just feeling generally fed up, not motivated, also low libido. And libido doesn't just mean reduced sexual desire, it means also that joy for life. It's feeling the wind in our hair, it's feeling the rain or the sun on our face, looking out of the window, thinking how lovely it is to be alive. Those sorts of symptoms, when they're not there, those symptoms can be due to testosterone deficiency. Now, we presented some data a few months ago at an international conference, and we found, or we find in our clinic, when we do this symptom questionnaire on women every time they come to the clinic, those women who are already on HRT, we offer testosterone to those women who have reduced libido despite being on HRT, because that's what the guidelines say, an indication for testosterone. But we have found that the mental health improvements actually are more statistically significant than the libido improvements. So the low mood, the anxiety, the negative thoughts all improve actually more significantly than the libido improvements. Not for everybody, but for a significant proportion of women. And actually we have more improvement in mood symptoms than we do in libido improvements for women. And in the clinic, I often say to women, you know, I haven't got a crystal ball. I have no idea how you're going to improve or maybe not improve in the future. All I know is that the hormones I prescribe are safe. They are just a replica of our natural hormones. And all I'm going to do is give you the dose and type that's right for you at this time for you. It might need adjusting, they might need changing. We'll work together and then we can see what symptoms improve. And of course, if your mental health symptoms don't improve or worsen, then we can talk about other treatment options. Any treatment with hormones and testosterone is also done alongside looking at lifestyle alterations as well. But for a lot of women, having their hormones balanced first makes it a lot easier then to think about lifestyle changes. So we shouldn't be setting ourselves up to fail by avoiding HRT. And I know there's massive conversation out there at the moment, and it's been going on for decades about hormones. And there seems to be so much that against women having their hormones. All we're talking about is natural hormones. We don't have this discussion for other hormones such as thyroxine or insulin. It just doesn't make sense to me, because there isn't data that show that natural hormones are unsafe. Because why would we be making them as women? Why would they be biologically active in our bodies? Of course it makes no sense. What we're lucky, I suppose, is that we're living longer because of advances in medicine, but that means it's longer without our hormones. So many people will say it's a natural process. Being menopausal, it's just what nature intended. Well, actually, there's lots of things that happen as we age. And we know, for example, raised blood pressure can occur as we age. We don't ignore it because there are health risks with raised blood pressure. And that's exactly the same with the menopause. What it's really important is that women are educated about hormones, and then they can decide whether they want them or not. But for many, many years, we've tried everything else other than hormones. You only need to look back into the 50s and 60s, how we treated mental health symptoms related to the perimenopause and menopause. Women have been given benzodiazepines, they've been given amphetamines, they've been given barbiturates, they've been had operations to remove part of their frontal lobe. Even in the 1800s, they used to remove women's clitoris because they thought masturbation was the cause of these mental health symptoms. They used to obviously worry about it being our womb that was the cause of our hysteria. And if we think of the word hysteria and hysterectomy, how closely they're associated. So in the history of time, people have always worried about mental health, and they've associated it with women's periods, with the cycle, but they've never thought long and hard enough about how important our female sex hormones are for our brain function. But I feel the tide is turning because people are understanding it more. As an organisation, my company, Newson Health, are working very closely with psychiatrists. I trained a whole group of psychiatrists and mental health workers last week for the NHS in Surrey, and the response was really, really positive actually. We're writing a training programme with the Royal College of Psychiatrists, which is due to be out soon. So psychiatrists are really embracing it. They've never been taught about hormones. They often don't know how to prescribe HRT, but they're listening and they're very progressive, and we really hope that the conversation will change. A lot of it will change though if you listening actually ask for hormones as well and say, look, I'm just wondering whether some of my symptoms could be related to my hormones, and I'd really like my hormones rebalanced, and then I can see what other drugs I need or what my diagnosis really might be. Especially if you've had a history of postnatal depression or PMS and PMDD, it's likely you've got this sort of reproductive depression or associated with being perimenopausal or menopausal. So I know that's a lot that I've spoken about, and I could talk about it a lot longer because it's so important. But I will keep posting things on my Instagram about the power of hormones in our brains, the role of our hormones, oestradiol, progesterone and testosterone, and how they interact with other neurotransmitters as well. And we just need to think about basic science. None of this is that complicated. It's just been forgotten for decades to the detriment of women. So have a think, have a read, have a listen. You might need to listen to some of this again. But I hope that's been helpful. I'm going to put this on my grid now. And next week, I'm very happy to talk about anything else. I was thinking about talking about surgical menopause because I know that's something that comes up a lot, and a lot of people that have had a surgical menopause often feel quite neglected and not listened to. So I'll talk about surgical menopause. So that's a menopause if your ovaries have been removed, but also I'll talk about people who've had a hysterectomy and haven't had their ovaries removed. And I'm also going to include in that about a medical menopause, so people that might have had their ovaries damaged by certain medication, or their ovaries switched off by other medication as well. So I'll try and include all of that next week. If you've got other ideas for topics that you want, then put them in the comments below this post and I'll start planning ahead. And I'm very happy to give my time up. It's not much time really, for half an hour or so on a Sunday evening. And if it's helpful, let me know. If it's not helpful, let me know as well, and I'll have my time back with my family. But I'm really keen to keep going and give you as much evidence-based information and also basic science that I can. So enjoy the rest of the evening. Keep warm for those of you that are in the UK, because it's very cold here, and see you next week. Thank you.